Hello, and welcome to Strategies for Assessing and Managing DOAC-Related Bleeding. I'm Dr. Deborah Siegal, and I'm a hematologist who practices thrombosis medicine. I'm an associate professor at the University of Ottawa. The overall learning objectives of this program are to assess further bleeding risk for patients who are on an oral anticoagulant, select appropriate DOAC reversal or replacement agents for patients with severe life-threatening bleeding, and advise clinical colleagues on the appropriate management of DOAC reversal therapies. So while we're discussing reversal strategies for DOAC-related bleeding, it is important to remember that bleeding is the major complication of anticoagulation, and about 2 to 4% of patients each year experience major bleeding. Another 10 to 12% of patients experience clinically relevant non-major bleeding. And what's also important to recognize is that while we often focus on intracranial bleeding because it is the most feared complication with high associated morbidity, mortality, gastrointestinal bleeding or GI bleeding represents up to 50% of major bleeds. And this is the single most frequent site of bleeding. And we're fortunate to have access to direct oral anticoagulants or DOACs, which reduce the risk of intracranial bleeding, major bleeding, and fatal bleeding compared to warfarin. But it's also important to keep in mind that anticoagulant-related bleeding complications represent the most common adverse drug event, which leads to emergency department visits, hospital admissions, and death. This slide shows the mortality rates after anticoagulant-related major bleeding complications in the large phase 3 clinical trials of DOACs versus warfarin for atrial fibrillation. And you can see here, although this is not a meta-analysis or a synthesis of the data, but just to show that the rates of mortality after warfarin-associated bleeds ranged from 11 to 14%, and DOAC-related bleeds 7 to 10% in these studies. And we'll also see in a few slides that 30-day mortality rates among patients who were receiving DOACs and received reversal therapies was also high at around 11 to 14%, which means that this is an important complication for our patients, and that good clinical management really will help improve outcomes. This slide summarizes the risk of death after different types of bleeding complications in patients on oral anticoagulants for atrial fibrillation. And you can see that hemorrhagic stroke here has the highest associated risk of death with a hazard ratio of almost 27. Subdural bleeding here is almost a hazard ratio of 7, and extracranial bleeding, importantly here, increases the risk of death by about 5-fold, which emphasizes that extracranial major bleeds are also quite significant. This slide summarizes the mortality after DOAC-related major bleeding for patients who received specific reversal agents. In the REVERSE-AD study, which evaluated idarucizumab, which is a specific reversal agent for dabigatran, and Anexa-4, which evaluated andexanet alpha, which is a specific reversal agent for factor Xa inhibitors. You can see that while hemostasis was achieved in about 70 to 80% of these patients, mortality was high, ranging from 11 to 14%. And you can see that the numbers were similar for mortality in the entire cohort, which included patients with diverse bleed types, including intracranial hemorrhage. And in fact, in the Anexa-4, that study was enriched for patients with intracranial hemorrhage. But also in the patients who experienced GI bleeding as their index bleeding event, mortality was high at 11%. Within 30 days, which means that these patients who are elderly with multiple medical comorbidities have a high rate of adverse events and complications after bleeding. And of course, bleeds are not all the same, so they can't be treated all the same. We see on the left-hand side of the screen, these are just some representative examples to illustrate the point that bleeds are diverse. And in fact, they have different etiologies and different risks of rebleeding. On the left-hand side of the screen, you can see different types of gastrointestinal bleeding, which we see routinely in clinical practice. And we know from our clinical experience that these all present, and the natural history is quite different. And then on the right-hand side of the screen, you can see also a representative image showing the different risks of rebleeding after different types of intracranial hemorrhage. Traumatic is, of course, generally associated with a lower risk of rebleeding compared to spontaneous intracranial hemorrhage. And you can see that subdural hematomas here also have a variable risk of rebleeding depending on the underlying etiology, whether traumatic or spontaneous. And that's something important to keep in mind as we move forward and understand strategies for management, including reversal and also restarting anticoagulants after bleeding. And again, this is another slide which summarizes the impact of bleed type on overall mortality. This is a sub-study of the Aristotle phase 3 clinical trial, which compared apixaban versus warfarin. And you can see here that they measured mortality after intracranial and non-intracranial bleeds, 43% mortality among individuals who had intracranial bleeds, and 9% mortality within 30 days among those who had extracranial bleeds. So in summary, the point of these slides is really just to say that not all bleed types are the same, and that although intracranial hemorrhage is the most feared with very high morbidity and mortality, extracranial bleeds are actually quite relevant and important as well. But it's not just about mortality here. We know that bleeding complications impair quality of life. And you can see on the left-hand side of the screen here that major GI bleeding is associated with reductions in quality of life early after onset. And although this improves over time, we see that the quality of life is impaired up to 12 months after bleeding events occur. And with regards to intracranial hemorrhage, you can see that functional outcomes are a really important part of assessment. On the right-hand side of the screen, you can see the modified Rankin scale, which is a measure of functional status. The darker green boxes show scores of 4, 5, and 6. And these are unfavorable outcomes. 6 is, of course, death. And you can see that after intracranial hemorrhage, the majority of patients experience an unfavorable outcome. And this does not improve very much over time. So even among survivors, adverse events are very important to quality of life and functional status. So where do we put all of this? How do we use this in clinical practice? Well, it's important to remember that if these events are frequent and are serious, then we really need a multimodal bleed management framework in order to optimize care. Prevention is the first step when you're starting anticoagulation for patients. It's important to do that and be mindful of modifiable risk factors for bleeding and to counsel around bleeding. We can talk a little bit about that later. It's important to protocolize management of bleeds with access to early supportive measures, monitoring, and invasive procedures or interventions that can stop bleeding. Reversal strategies are indicated for patients with severe life-threatening bleeding, and if reversal agents are not available, hemostatic therapies like prothrombin complex concentrate or PCC can be given. And then finally, it's really important to remember to reassess anticoagulants after bleeding because these patients have an underlying prothrombotic condition for which they're receiving anticoagulants in the first place. So in the long term, these are the steps really that we take in our clinic in order to ensure that we're providing optimal care and safe anticoagulation for patients, making sure that they have blood testing, that we evaluate concurrent medications, that we're using the right drug and dose for the patient and their characteristics. The patients are provided with education and counseling and what to do if and when they're having an emergency. A routine follow-up is important because it allows us to review things like the indication and to evaluate and address bleeding risk factors over time.
Hello, I'm Dr. Alexander Cohen, a vascular physician and epidemiologist at Guy's and St Thomas's Hospitals, King's College, London, UK. And I'm going to be talking about assessing risk of DOAC-related bleeds. Hello, I'm Dr. Alexander Cohen, a vascular physician and epidemiologist at Guy's and St Thomas's Hospitals, King's College, London, UK. And I'm going to be talking about assessing risk of DOAC-related bleeds. The learning objectives are to assess further bleeding risks for patients who are on oral anticoagulants and to select appropriate DOAC reversal or a replacement agent for patients with severe or life-threatening bleeding. The management of DOAC-related bleeds has been described by the European Society of Cardiology. And in this slide, we can see that it's for life-threatening bleeding that we need the reversal agents. Bleeding can be divided into mild, non-life-threatening, and life-threatening. And the European Society of Cardiology recommends the use of reversal agents, specific reversal agents for life-threatening bleeding. And this also should be considered for uncontrolled bleeding. But the initial assessment of a patient requires you in the accident and emergency department to look at the site of the bleed and decide whether it's a critical site or a non-critical site. Is the patient in shock? What's their perfusion like? And what's their mental state? Are they confused because they're hypotensive or shut down? First of all, we have to decide what the severity of the bleeding is. And we do see nuisance bleeding often known as clinically relevant non-major bleeding. And this can involve a number of things like bruising or nosebleeds that are easily managed. We then also have to consider if bleeding is more considerable and what would be called major bleeding or critical organ bleeding as one type of major bleeding. Now, what do we mean by critical organ bleeding? Well, critical organ bleeding could be, for instance, a bleed into the eye. Not what we see in the top half of this slide, which is a subconjunctival hemorrhage, which is a minor bleed, but the hyphema that we see in the lower half of the bleed. That's an intraocular bleed, like retinal bleeds and vitreous bleeds. We also have to be concerned about other critical organs like the brain with intracranial bleeding, where there's intracerebral bleeds, subdural bleeds, epidural bleeds, and subarachnoid bleeds. And there are other critical sites too, like the pericardial bleeds and bleeds into joints and bleeds into the retroperitoneal space. Once we make that assessment, we can see whether it's a critical organ. Are they in shock? Is there loss of perfusion, or is transfusion required? Because if it's not a critical organ, it's likely to be a bleed from the GI tract, the commonest cause of a non-critical site bleed, the respiratory tract, or the urogenital tract. And that's where most of bleeds occur. And these become major bleeds when the patient has a fall in hemoglobin or requires a transfusion. What's first in this situation when we see a 75-year-old patient brought in by ambulance with massive GI bleeding? And this is not uncommon. In fact, it's the commonest site of major bleeding. How do we manage these patients? We need to assess their cardiovascular state, and we need to consider giving fluid therapy straight away. Bleeding can be from the upper GI, and that's associated with a higher risk of mortality. And it can be from gastric erosions or even patients with duodenal ulcer. The important thing to consider is how frequent bleedings are. And in this study, which we presented at the ISTH this year, we looked at hospitalizations and mortality by anatomical site. And we can see that hospitalizations were highest for gastrointestinal bleeds in orange, for genitourinary bleeds in yellow, for obstetric bleeds in pink, and intracranial bleeds in purple. There were other bleeds too that were common, like respiratory bleeds in blue, and trauma and surgical related bleeds in grey. And we looked at this over a 5-year period, and there was a very steady number of patients coming in with each of these types of bleeds. But it's GI bleeds that lead to the greatest burden of patients with major bleeding, closely followed by intracranial bleeds, because we can see in these straight lines that the mortality rate is highest for intracranial, next highest for aortic aneurysms, and then we have gastrointestinal bleeds. When we consider these patients in the ED, we know it's a critical organ, or if it's not a critical organ, they need transfusion and resuscitation. And these are the patients that we need to consider for reversal agents. What about patients that have traumatic bleeds? Well, we see really enormous amounts of blood being lost into major bone fractures. And in this patient with a hip fracture, we can see that there is a lot of swelling around the hip joint. And these patients can also have significant uncontrolled bleeding. In these patients, these emergency cases with severe bleeding, and then where there's little time to determine DOAC levels, which measures should be used to assess the presence of oral anticoagulants? Should we use the PT, or the prothrombin time, the TCT, the thrombin clotting time, anti-10A levels if they're available, or all of the above? Well, actually, all of them are useful. And generally, it's recommended to look at the PT and see whether that's elevated. It's probably a slightly more sensitive measure than the INR. There's often no time for drug levels. And in this 75-year-old we saw who had the GI bleed, they were brought in by the emergency service. What do we do in that situation? We can do the PT, and the INR is, as I said, slightly less useful, but anti-10A levels correlate well, and particularly if they're calibrated to the particular drug. And the APTT may be useful for direct thrombin inhibitors, and the thrombin time, if available, is better. In a bleeding patient, you need to ask the right questions, and you need to be sure about when that anticoagulant was prescribed and when that anticoagulant was taken, because in this situation, that determines how they're managed with the reversal agent. Is the anticoagulant present in high quantity? And when the last dose was taken, what's the half-life? And the renal function also determines the clearance of the drug in an individual patient. And then the site and severity of the bleed. Can we use any local measures? And is reversal necessary? This is a case of an 83-year-old woman who presented with some neurological signs, and she had a history of atrial fibrillation, hypertension, chronic obstructive pulmonary disease, and she was treated with rivaroxaban 20 milligrams, and her last dose was 5 hours ago. She was normotensive, and she had a normal pulse rate, but she had signs of a stroke. And her PT was elevated at 13.2, as was her APTT. And the question remains, would you consider reversal of rivaroxaban in this patient? And I think most of us would, particularly in someone who's taken their anticoagulant around 5 hours ago. This is the course of this patient. She was entered into the Annexa 4 study. She had a diagnostic CT, which showed the intracerebral hemorrhage. She had her first study CT 6 hours later, which showed minimal increase in volume. And then she had her second study CT 12 hours later, which showed no change. This patient, by day 30, had full resorption of the bleed with no visible blood, and she was discharged to rehabilitation, and after 30 days started on a reduced dose of apixaban. Her last follow-up, 5 months after discharge, showed she functioned independently, but had a persistent mild paresis. The next case is a 63-year-old man who presented at the emergency room with hemorrhagic shock and melena, and he'd had an endoscopic resection of a Barrett's esophagus and restarted on rivaroxaban 24 hours later. The indication for rivaroxaban was paroxysmal atrial fibrillation, and he also had diabetes and morbid obesity. His usual dose of rivaroxaban was 20 milligrams, and he presented shut down with cold extremities, hypotensive, and his pulse rate was 128. His body weight was 151, and his laboratory findings, including his coagulation profile, showed no abnormalities. So the question here is, would you consider reversal of rivaroxaban in this man? And I think many of us would, given that he's in extremis, and this is a life-threatening bleed at the moment. In his case, andexanet was not available, and he received 4,000 units of PCC based on his ideal body weight and some tranexamic acid. He had fluid resuscitation, and he had 2 units of red blood cells and vasopressor treatment and went to ICU. They discontinued rivaroxaban, And in his case, endoscopy was withheld due to technical difficulties. His anti-10A level on rivaroxaban was not high. It was 49 nanograms per litre, but still may have contributed to his bleeding. Why is bleeding becoming a more and more important issue to understand? And mainly it relates to the risk factors, because the risk factors are becoming more common. And this particular table from the European Society of Cardiology guidelines I find very useful, because it divides patients with modifiable bleeding risk factors in the top left, on the bottom left, potentially modifiable risk factors, on the top right, non-modifiable risk factors, and in the bottom, some biomarker-based bleeding risk factors. And these modifiable risk factors are things we should look at all patients we manage with anticoagulation. And I've put some red squares in this slide because all these factors marked with red squares are more prevalent with age. And in the Western world, we live in an aging society. We live in aging populations, and these will become more and more common, as will the diseases that require anticoagulation. There are a number of risk scores that predict the risk of bleeding, but one of the risk scores predicts the risk of mortality and allows stratification into low and high risk bleeds, low and high risk of mortality related to the bleeds. So is that the HAS-BLED score, the ORBIT score, the Rockall score, or the Glasgow-Blatchford score? And the answer to this is it's the Rockall score. So both the Rockall score and the Glasgow-Blatchford score allow immediate care and risk stratification for GI bleeds. But it's the Rockall score that allows us to predict the risk of mortality and stratify patients into low and high risk of bleeds. And this takes into account age, shock, comorbidities, the type of GI bleed, and whether there are major stigmata of recent hemorrhage. The Glasgow-Blatchford score is also useful, but it is more investigation-based, looking at things like blood urea levels, systolic blood pressure, hemoglobin, and other markers. And when we look at the Rockall score, if we look at these series of histograms, we can see mortality on the y-axis and the risk score on the x-axis. And as the risk score increases, we can see that the risk of mortality increases for those that don't rebleed and those that rebleed. So this is a very useful score for determining whether patients are going to benefit in general, we think, from reversal agents. So we developed a proposed clinical pathway for factor Xa inhibitor-associated bleeding patients. And we divided this up into patients with intracranial hemorrhage, patients with epithelial bleeds like GI bleeds, but this could also apply to patients with respiratory tract bleeds or urogenital bleeds, and patients with trauma. And for the intracranial hemorrhage patients, we recommended urgent imaging with a CT or MRI, and then an opinion of a neurologist and intensive care doctors or a stroke centre. And once ischemic stroke's ruled out, to consider the use of an antidote. For GI hemorrhages, same sort of process, managed in the emergency department often in conjunction with ICU doctors and GI doctors to get an urgent endoscopy and blood transfusion, and then to consider antidote therapy. The trauma patients are seen by a range of people in emergency department, perhaps a trauma centre, intensive care doctors, surgeons and anaesthetists. The view would be that from the anaesthetist would be to recommend the use of an antidote where appropriate, or to get the opinion of the trauma surgeon. In all these cases, We need to have well-trained nursing staff in emergency, ICU, and well-trained pharmacy staff who can facilitate the use of the antidote. In general, my key takeaways are we need to consider the following factors in deciding to use DOAC reversal agents in patients experiencing bleeding. First of all, to consider what's the bleeding location and what's the severity. Is this a critical site, which is associated with high mortality, or is this a patient who has bled a considerable amount requiring transfusion or a significant fall in hemoglobin? Then to consider the type, the dose, and the time since the last DOAC, the kidney function with the creatinine clearance and hemoglobin, and a coagulation assessment, including plasma drug levels if available. We need to differentiate Eustace bleeding from major bleeding and critical site bleeding. And if time is limited, we can use prothrombin time, anti-10A levels if available, activated partial thromboplastin time, and thrombin clotting time, which will help let us know whether there's anticoagulant present. And also to manage the bleeding risk factors, as I showed you in those slides from the European Society of Cardiology, in order to reduce the risk of further bleeding. Many thanks for your attention.
Hello and welcome to this CME program, which deals with DOAC or direct oral anticoagulant reversal agents. My name is Jan Beyer-Westendorf. I'm a thrombosis and hemostasis consultant at Dresden University Hospital in Germany. The objectives of this session is to discuss with you the appropriate selection of DOAC reversal strategies or replacement agents for patients with severe or life-threatening bleeding. And I'd like to advise clinical colleagues on appropriate management of DOAC reversal therapies. Why is this topic important? You all know that more and more patients receive anticoagulation, and with the availability of direct oral anticoagulants, which offer a better safety profile compared to the old vitamin K antagonist therapies, more long-term treatments are provided, and we extend treatments to patients at higher risk for bleeding as well, which we would not have treated with vitamin K antagonists in the old days. But still, we're talking about elderly patients, comorbid patients, so DOAC-related, or in this case, direct factor 10A inhibitor-related emergencies are common scenarios in routine care. When a patient arrives in such an emergency situation, urgent decisions are asked for. And we need to decide whether we want to use a reversal agent or not. This decision obviously has a high impact on clinical outcomes. Let's start into this topic by looking at a case. Here we talk about a 73-year-old female lady with atrial fibrillation. She experienced a fall in the bathroom in the early morning, and she was admitted to our emergency unit with the suspicion of a hip fracture, which was then confirmed in X-ray. From the fall, she also had a small laceration on the back of her head. When we asked about her history, she told us that she's on rivaroxaban, which is one of the direct oral anticoagulants, and she was taking it for atrial fibrillation at the dose of 50 milligrams once daily. And the last intake was about 6 hours before she fell in the bathroom. She's also taking aspirin for peripheral artery disease with stents. And while our trauma surgeons were preparing everything for the hip fracture surgery, the lady developed neurological deterioration in our emergency room. So from the laceration of the back of her head, we know she also had a head trauma. So what we did is a CT scan. Here you can appreciate this bleeding at the back of her head. So obviously this lady has an intracranial hemorrhage, while she's taking aspirin and rivaroxaban. Now, especially when we talk about intracranial hemorrhage, we know that time is brain, because as bleeding continues, the pressure in the bleeding side on the brain tissue will increase and will contribute to damage to the brain. When the patient first starts with an asymptomatic phase, and once the bleeding has reached a certain size, then the patient will develop symptoms, but then some time will go away until the patient is presenting to our emergency unit. Once the patient has arrived, we need to come up with a decision for or against an antidote administration, and then we need to prepare the drug, we need to give the drug to the patient. Time will elapse until the reversal treatment is effective. And then the big question is the duration of this reversal activity. Please be aware that there are time delays that we cannot influence, and these are the preclinical time windows. So the asymptomatic phase and the phase until presentation in our hospital. But on the right-hand side in the blue boxes, you can clearly see that we have 3 important time windows that we can actively influence. Time to decision, time between administration of an antidote and onset of the action, and time until offset of the action. So throughout the presentation, I will focus on the blue boxes here on the right side, because those are the timeframes we can actively influence. We have to make decisions under time pressure. And the questions we need to answer are, is the DOAC, the oral anticoagulant or the direct factor Xa inhibitor, actually the cause of the present intracranial hemorrhage? Because if it's not, then we don't need to consider reversal. And to answer that, we need to know about DOAC type, the dosage, the time of last intake, to enable us to consider whether this DOAC still is in the patient at relevant plasma levels. There are other reasons for intracranial hemorrhage that are equally or more likely. Does the patient have antiplatelet therapies? An uncontrolled hypertension is maybe there is a ruptured aneurysm. So if you have an open vessel, it doesn't take a DOAC to contribute to the bleeding. So the next question we need to ask ourselves is andexanet alpha reversal available in my hospital? Are there alternatives for andexanet alpha reversal if it's not available? Are there contraindications in this specific patients to use andexanet alpha reversal? All of these questions we have to answer as fast as possible. Now, back to our case. The first box you see here in red are the questions: DOAC type, dosage, last intake. And we have a conscious patient. This lady can clearly tell us she's taking rivaroxaban at dose of 50 milligrams once daily for atrial fibrillation, and the last intake was about 6 hours before she arrived in the hospital. This gives us a good idea that she's close to peak levels. So we know that the DOAC, when you give the tablet some 3 to 4 hours later, the highest concentration in the blood is reached. So if this patient now presents 6 hours after intake of rivaroxaban, we can be pretty sure that there are considerable amounts of the drug still in the patient, so close to peak levels. For a patient on a high dose of factor Xa inhibitor, what is the cutoff time for a previous dose, after which only a low dose of andexanet should be used? This is something to think about for you. I'll give you 2 seconds to make up your mind. Here is the answer. You see, on the left-hand side, there is a table for recommendations of andexanet alpha dosing. And you see it depends on the type of the DOAC, of the last dosage taken, and of the timing of this last dose. And you see that the critical value is 8 hours. If the patient was taking rivaroxaban at a dosage of larger than 10 milligram, which is the case in our patient. And within the last 8 hours, the patient should be treated with high dose of andexanet alpha. But the same patient taking rivaroxaban at a dosage of 50 milligram once daily, and the last intake is longer than 8 hours ago, then you would treat the patient with low dose. Basically, this holds true for all the direct factor Xa inhibitors. Beyond 8 hours, it's always low dose, but the difference is in the time frame in between 8 hours. You see that for rivaroxaban, low or high dose depends on the last dosage taken, but the same holds true for apixaban or edoxaban. So the take-home message is, within 8 hours, you need to be sure which dosage was taken to come up with the right amount of andexanet alpha to reverse this DOAC. After 8 hours, for each DOAC and each dose, it's the recommended andexanet alpha dose is low dose. And on the right-hand side, you see what is meant by high dose or low dose. You see in the upper part on the right table, the low dose consists of 400 milligram IV bolus, which is 2 ampules, followed by 480 milligram infusion over 2 hours, which is roughly another 3 ampules. So what you need for low dose is 5 ampules. If the patient needs to be treated with high dose andexanet, it's the double bolus. So it's 800 milligram andexanet alpha, 4 ampules, and you give it over 30 minutes as an IV bolus. And then you follow with 5 ampules or 960 milligram over another 2 hours. So low dose, you need to prepare 5 ampules, and for high dose, you need to prepare 9 ampules of 200 milligram andexanet alpha each. This has been settled for our patient, but now let's take a curveball to the story. What if? What if we don't know about the last time of intake or the exact dosage that was taken last? Can we still somehow estimate whether the patient has relevant plasma levels of the factor Xa inhibitor in the blood? So what would you do at this situation? We don't know the exact dosage the patient is taking, maybe because the lady comes in unconscious, and we don't know exactly the time of the last intake. Would you wait for a specific DOAC level test result? Would you proceed with reversal anyway? Would you say, okay, then I can't reverse at all? Or would you do something completely different? Again, I'll give you 2 seconds to make up your mind. Here, the story continues. Our patient is anemic. The lab shows an INR of 2.4. The APTT is normal. We do see mild elevation of her D-dimer. We see impaired renal function with the eGFR of 37 mils per minute, and the liver enzymes are normal. Anything here that is of help for you? Well, we could do a chromogenic anti-10A assay for rivaroxaban. It is in-house available at 24/7, at least in my hospital, but in many other hospitals around the world, this is not the case. But even in my specialized setting, our turnaround time is 45 minutes for the result to come back once the lab sample is in the lab. So it will take about an hour from me when I sample the blood sample until I get the result of the anti-10A assay. Clearly, in a patient with an ongoing intracranial hemorrhage, 45 minutes or 60 minutes for decision-informing lab value is not good. So not ideal here. But we see the patient is anemic, and especially she has an INR of 2.4. What we know is that in some labs, high DOAC levels can impact global coagulation tests such as PT or INR. And this is the case for labs which use a PT assay that is very sensitive to DOAC presence. In our hospital, that's the case. So an INR of 2.4 tells me that very likely this is caused by a rivaroxaban action. So it's a lab artifact. You can't really act on INR 2.4. It's not the same as INR 2.4 with vitamin K antagonist, but it's in a DOAC patient, an abnormal INR can tell you or can help you if you know about the sensitivity of your lab to identify patients very likely to have higher values of a DOAC in their blood. What we also see in her lab that she has impaired renal function with an eGFR of 37 mils per minute. And we know that as chronic kidney disease progresses, it does prolong DOAC half-lives. The DOACs are at least in part renally excreted. So if you have a patient here where you know she is taking rivaroxaban, where you see the INR is 2.4, and where you see she has impaired renal function, you can at least expect to some degree that she will have higher plasma levels of rivaroxaban in her blood compared to a patient with a normal renal function. And the INR of 2.4, as I said, gives you an idea that there might be considerable amounts of rivaroxaban in the blood. I say, if you focus now on the right-hand side, that even if I would not know about the last intake and the last dosage, based on the INR and the impaired renal function of this patient, relevant plasma levels are highly likely. So I would not wait for chromogenic anti-10A assay to come back in 45 to 60 minutes. I look at the INR, I look at the eGFR, and I would indicate a DOAC reversal in this patient. The next question here, are there other reasons for intracranial hemorrhage that are equally or more likely to contribute to the intracranial hemorrhage? And here you see the patient is also taking aspirin. So she is on an antiplatelet drug that doesn't help in this setting. So please do not only focus on rivaroxaban reversal, but you should also consider dealing with the aspirin part of the equation. So in some sites, tranexamic acid is being used in this situation. Other sites use platelet transfusions, which is not recommended by guidelines to counteract antiplatelet therapies in a patient with a chronic intracranial hemorrhage, but still it's something worth to consider. The next questions, is andexanet alpha reversal available in my hospital? In my hospital, the answer is clearly yes. And it should be available in many hospitals around the world. And this is the reason. We know that based on the data of the ANNEXA 4 study, which was a non-randomized study, it was a single-arm study where we used andexanet alpha to reverse apixaban and rivaroxaban anticoagulation in routine care patients. These data led to approval, at least conditional approval by the FDA for North America and by the EMA for Europe. And here you see the database for this conditional approval. On both figures, on the upper panel, you see for apixaban patients, lower panel for rivaroxaban patients. You see the baseline box plot gives you an indication or an idea of the baseline levels of anticoagulation activity of apixaban and rivaroxaban. And then you see when andexanet alpha was given at the end of bolus, which is the second box plot in both figures, you see end of bolus, there was an immediate decrease of the anti-10A activity of apixaban or rivaroxaban, really down to nearly zero. And this persisted until end of infusion. And for both drugs, apixaban and rivaroxaban, there was some reuptake of anticoagulant action 4 hours after the end of infusion, which is a problem of redistribution from the deep compartment. But overall, you see that andexanet alpha is immediately active when you give it as a bolus and follow up with an infusion. And for as long as you infuse, you have the action of andexanet. On the left-hand side, you see the actual numbers that the reduction in anti-10A activity at the end of bolus was achieved to 92%, both for apixaban and rivaroxaban. So 92% of the overall drug action in the patients was reversed by the bolus alone, which is an extremely good value for an emergency antidote. And as I said, this has led to the approval of the drug. So if you work in a jurisdiction where the drug has been approved, it is up to you and up to your hospital pharmacists to make sure that the drug is being made available in your hospital, because obviously by FDA and EMA, it has been approved and made available. So availability, yes. The next question is, are there alternatives for andexanet alpha reversal? And all over the world, I hear when I talk to colleagues and peers, well, we can use PCC or prothrombin complex concentrates, which is a factor concentrate. Not so sure whether this is truly an alternative to the highly specific reversal with andexanet alpha. And here are the reasons. These are results from a healthy volunteer study where patients were loaded with apixaban and then they were counteracted, I'm not saying reversed, but counteracted by PCC application. And it was actually a good PCC, so it was a 4-factor concentrate. But what you see is PCC replaces missing factors in the bloodstream, but is not a specific drug to reverse a DOAC action, because on the left-hand side, you see whether the patient received Cofact or Beriplex or placebo on top of apixaban, there was no impact of PCC on the apixaban concentration. On the right-hand side, the anti-10A activity caused by apixaban was also not changed with placebo, Beriplex, or Cofact PCC concentrates. So PCC does make nothing with regard to apixaban concentration binding to apixaban or reversing anti-10A activity of apixaban. What PCC does is it provides an overflow of anticoagulant factors that may override the anticoagulatory efficacy of apixaban. But this is far from being a specific reversal. Now, this was the lab side of things, but look at the clinical side of things. So far, we don't have randomized controlled data for andexanet versus PCC, but we have plenty of indirect real-world comparisons. And you see here a list of studies where DOAC-treated patients were treated with andexanet alpha or PCC. And in the last column, you see mortality differences. And in the last but one column, you see the effectiveness data for andexanet alpha or PCC. And here highlighted in red, you see all the data fields where we do see a beneficial effect of andexanet over PCC. Might it be increase in the cranial hemorrhage volume? Might it be other effectiveness measurements? Or might it even be mortality? The black boxes here in this table, where the results were neutral or not reported. And in one case, the mortality data of the FAM et al. US data set indicated higher mortality with andexanet alpha. But in all other data fields here highlighted in red, you see a benefit for andexanet alpha. So as I said, these are not randomized controlled data, and we need to wait for the ANNEXA-E study or ANNEXA-I study, which is the randomized controlled trial for andexanet alpha versus standard of care, which does include PCC. And it will take another year or two for us to get the final RCT results. But until then, this is what we have. And I think the data are robust enough and consistent enough to conclude that PCC is definitely not better than andexanet alpha. Maybe it's even the other way around. We might even come to the conclusion by looking at this table that andexanet alpha is the more beneficial drug in this setting. The next question we have to answer on our patient, are there contraindications for andexanet alpha reversal? And actually, apart from an hypersensitivity to the drug, which you would only be able to diagnose if the patient has been treated with andexanet alpha before, there are no relevant contraindications to consider. So we went through all the lists of questions I've introduced before, and there was not a single reason not to use andexanet alpha in our patient. So we would indicate immediate reversal of rivaroxaban by using andexanet alpha. And as I said, for a 50 milligram intake in some 6 hours ago, it should be the high dose of andexanet alpha. Now, let's introduce another curveball. What if? This case actually went a different way. So as I said, she originally came in with a suspicion of a hip fracture, which was confirmed in the X-ray. The attending trauma surgeon, when the patient came in, looked at her lab values, which I also introduced to you, and indicated 4,000 units of PCC, which is rather a high dose. So it translated into 60 units of PCC per kilogram body weight of Our Lady. And the reason for that is the PCC was given early after arrival in the emergency room, and the diagnosis was blood loss coagulopathy based on the anemia of the patient and the INR of 2.4. So this trauma surgeon was not aware of the fact that rivaroxaban can have an artificial impact on the PT measurement or the INR measurement. So he thought it's the blood loss of the patient that led to an elevation of the INR, and that's why he wanted to use PCC in this patient. And she also received 2 units of red blood cells to correct the anemia before surgery. So this was all done before we had to make up the decision whether we should use andexanet alpha reversal in our patient. So the question to you is, what would you do if a patient potentially benefiting from specific andexanet alpha reversal had received a shot of PCC already? Would you wait for lab test results to assess the effectiveness of PCC? Would you still reverse with full dose of andexanet alpha because you made up your mind, Riva 15 once daily within the last 6 hours, this is the adequate dose? Or would you say, okay, we did something already with PCC, now let's go with a reduced dose of andexanet alpha, it's better than nothing, but maybe the full dose is no longer necessary after PCC? Or would you not use andexanet alpha on top of PCC? So this was actually what happened to the patient. She received PCC, and then I got called with the question of the neurosurgeon whether I would approve the use of andexanet alpha on top of PCC. And I said, no, you've made up your mind. The patient has received PCC already, which for me is a contraindication to use andexanet alpha on top. It is not a stated contraindication in the package insert in most countries, but it is something, I'm coming to the point in a second why I think we should not do this. Here is a CT scan of our patient on admission. You see the ugly intracranial hemorrhage on the back part of her brain. The middle figure shows you the surgical site 3 hours after operation with a follow-up CT scan. And on the right-hand side, the image is a control CT scan 2 days after surgery when she was already extubated and had a good clinical course. So obviously PCC did the job sufficiently to enable the neurosurgeon to drill out this intracranial hemorrhage. However, on day 4 after surgery, the lady developed a sudden severe dyspnea, a drop of the blood pressure, and tachycardia. So it was a pulmonary and circulatory collapse of the patient. We did an echo, and what we saw in an enlarged right atrium and right ventricle, it was actually as large as the left ventricle. We did find an increase in the right ventricular end systolic pressure. And when we suspected a pulmonary embolism and did a CT scan, we found this ugly pulmonary embolism bilaterally, so in both main stems of the pulmonary artery, large clots. So keep in mind, thromboembolism is a known complication after DOAC reversal. And I'm not saying that PCC or andexanet alpha is to blame. It's very likely that's the underlying thromboembolic risk of the patient, the reason why he is on a DOAC in the first place, is contributing to that thromboembolism risk, as does the emergency situation of bleeding, which activates coagulation, or surgery, which activates coagulation. All of that can definitely cause thromboembolism even outside of a reversal strategy. But as I said before, PCC is a potentially prothrombotic drug because it's a factor concentrate. it might drive the patient from an anticoagulant status into a procoagulant status on its own. So when the patient is on PCC or has received PCC already for treatment of a DOAC-related bleeding, I will not feel comfortable to add another potentially prothrombotic, but at least not anticoagulant drug such as andexanet alpha on top of PCC in this setting. The take-home messages of my presentations are: DOAC reversal intracranial hemorrhage is an emergency decision. Time is brain. Please keep that in mind. These blue boxes where we actually can have an impact, we need to shorten these timeframes as much as we can, because we cannot do anything about these green boxes of asymptomatic phase and time until presentation. Second, DOACs can impact the INR. In situation where we don't have an exact information how much DOAC was taken or what was the last time of intake, and if specific anti-10A assays are not available or take too long, an elevated INR may help to identify relevant DOAC levels in the absence of specific plasma levels. So please, when you go back to your hospital, talk to your lab people, ask them whether they use an DOAC sensitive assay to measure the PT, and if the answer is yes, you can at least see that if it's a very sensitive drug, a normal INR may rule out high levels of DOAC in the patient, whereas an elevated INR may indicate to you that this patient does have relevant DOAC levels. So it's not perfect, but at least gives you some help to guide your decision making. The impact on INR does not correlate with the anticoagulation effect of the DOAC. We know that there are false positive values, but also false negative values. But at least you can have some ideas if the assay is very DOAC sensitive. Last, if DOAC antidote is available and administration is considered, PCC should not be used before giving a specific antidote. So it's an either or decision. And from my perspective, also based off the real world data we've seen so far, my first concept would always be to go for this specific antidote, which is andexanet alpha for the case of the anti-10A drugs or the direct factor 10A inhibitors, whereas I would use idarucizumab, which is the specific antidote for dabigatran DOAC users. If PCC was already given, for me, it's a contraindication for both DOACs antidotes, andexanet alpha for the factor 10A inhibitors or idarucizumab for dabigatran users. With that, I thank you for your attention. I hope you learned a little bit about the concept of DOAC reversal, and that I especially hope that you feel more informed now and more comfortable to use andexanet alpha in this situation if you haven't done so already. Thank you very much for your attention, and goodbye.
So I'm going to be speaking now about managing patients who are receiving DOAC reversal agents. And the learning objectives of this section are to select appropriate DOAC reversal or replacement agents for patients with severe life-threatening bleeding, and to advise clinical colleagues on the appropriate management of DOAC reversal therapies. Again, if we revisit this multi-bleed management framework, we've already talked about addressing underlying risk factors for bleeding, protocolizing and managing acute bleeds, and providing reversal therapies. And now we're really into the phase of care where we're reassessing anticoagulants after bleeding has resolved. So this is a case of a 78-year-old male patient who's seen in the emergency department after a mechanical fall with a head injury, and he has a GCS of 13. He has a medical history that includes atrial fibrillation, hypertension, chronic kidney disease, osteoarthritis, and macular degeneration. And he takes apixaban 5 milligrams twice daily, which he just took 4 hours before his fall. He also takes perindopril, meloxicam as needed, and bisoprolol. His laboratory investigations show a stable hemoglobin. His INR is slightly elevated at 1.3, and his creatinine is 168, which is increased from his baseline of about 115. A CT scan of the head is done, which shows a subdural hematoma of 12 millimeters. So when managing this patient, it's really important to step back and address a few key questions. How severe is the bleed? Have supportive measures and interventions been initiated? What DOAC has been taken and when? Is the DOAC present in, quote, significant quantities? And is there a role for reversal? So when would we consider reversing anticoagulation for a patient? These are the scenarios where reversal of anticoagulation would be indicated, and they include severe life-threatening bleeding, critical organ bleeding such as the brain or spinal cord or pericardium, ongoing bleeding despite measures to control it, which is perhaps less common, bleeding with an expected long delay for hemostasis, also uncommon, but could include things like overdose or a severe renal impairment of a drug that is excreted by the kidneys, and then urgent surgery that can't be done safely while on anticoagulation and can't be delayed. So it is important to use reversal and hemostatic therapies judiciously. And so we limit their use to people, again, who have severe life-threatening bleeds, for people who have DOACs present in significant quantities, either because we think, based on our clinical criteria and some laboratory investigations, that that's present in significant quantities, or we know because we have a specific assay that will measure the level of drug in the bloodstream. And in those cases, if they have a severe bleed and the DOAC is present, then reversal agents like andexanet alpha or idarucizumab or hemostatic therapies like 4-factor PCC are warranted. So if we revisit this case of a 78-year-old male on apixaban who had a mechanical fall and has a subdural hematoma with some impairment in his GCS, he received andexanet by bolus followed by a 2-hour infusion. And of course, the dosing of andexanet is according to the timing of the last dose and the particular type of factor Xa inhibitor, apixaban or rivaroxaban, that the patient was taking. So he receives andexanet and is monitored in the neurocritical care unit for any deterioration. Because he's unable to receive anticoagulants at this time due to bleeding risk, he's provided with intermittent pneumatic compression devices for VTE prophylaxis. A repeat CT head done 24 hours later shows no hematoma expansion, and he's received some intravenous fluids now, and renal function has improved. A few days later, he's initiated on enoxaparin 40 milligrams subcutaneously daily for VTE prophylaxis. And on post-admission day 5, the neurology team is keen to get him closer to discharge, and they're wondering, when can we restart his apixaban? Which of the following is a key consideration for restarting oral anticoagulants in patients who have bleeding complications? A, high-quality data supports the net clinical benefit of restarting oral anticoagulants in all patients. B, thrombotic risk is the only consideration when starting oral anticoagulants. C, physicians should decide when to resume oral anticoagulants based on prior experience. Or D, modifiable risk factors for bleeding should be evaluated and addressed. And of course here, the correct answer is D, modifiable risk factors for bleeding should be evaluated and addressed. And in fact, part of addressing modifiable risk factors is understanding what contributed to the bleed in the first place. The etiology of the bleed, other risk factors. For example, our patient in our case was taking meloxicam in addition to apixaban. Meloxicam is, of course, an NSAID, so it'd be important to understand how that contributed and modify that therapy in order to improve safety. This slide summarizes the results of a systematic review and meta-analysis, which evaluated outcomes after reversal or hemostatic therapies for DOAC-related major bleeding. The outcomes that are shown include death, thromboembolism, and effective hemostasis. So while you can see that the majority of patients, 70 to 80% of patients, experienced effective hemostasis, and that's usually defined in these studies according to criteria described by the ISTH, a substantial proportion of patients died, up to 20% in this study, and about 5 to 10% of patients experienced thromboembolism. Of course, thromboembolism is an important consideration for patients who've experienced major bleeding complications while on oral anticoagulants. These patients are receiving oral anticoagulants for underlying prothrombotic conditions who've now presented with bleeding event. We've withdrawn their anticoagulant. We've perhaps reversed their anticoagulant effect. Their coagulation systems are activated in order to stop bleeding. They're critically unwell. Perhaps they have surgery or procedures, which further increases thrombotic risk. So what we see is that these patients are at risk of thrombosis after these events, and that it does remind us that it's important to reassess restarting anticoagulation after bleeding as soon as it's safe to do so. We see that thrombotic events occur in patients receiving reversal therapies for warfarin, and in fact, in the randomized controlled trial of patients treated with plasma or PCC for warfarin-associated major bleeds, we saw thrombotic event rates of around 7 to 8% as well. So again, important to recognize that patients who have prothrombotic conditions require a reassessment once it's safe to do so. This slide shows some results of the ANNEXA-4 study, which of course evaluated andexanet alpha in patients with acute major bleeding on factor Xa inhibitors. And you can see that in the whole cohort, so that includes individuals who had restarted and those who had not restarted therapies, the rate of thrombotic complications was 9.7% within 30 days, and the rate of rebleeding was 4.3%. And in a landmark analysis of patients who restarted an anticoagulant within 14 days versus those who were not restarted, you can see that patients who restarted had a lower risk of thrombosis and a higher risk of rebleeding. And of course, this captures exactly the conundrum that clinicians face in clinical practice by trying to understand these risks in order to make decisions about whether and when to resume anticoagulation after bleeding in order to optimize net clinical benefit of treatments. This slide summarizes the adverse events and the rates of antithrombotic restart after DOAC reversal in the REVERSE-AD and ANNEXA-4 studies. And you can see in the REVERSE-AD study, this was described at 90 days. Most of the patients had received some type of antithrombotic therapy, and that could have been oral or parenteral, unclear whether this was antiplatelet or anticoagulant. Similarly, for ANNEXA-4, 62% of patients restarted antithrombotics within 30 days. So that could have been parenteral, antiplatelet, or anticoagulant. And again, 28% restarted oral antithrombotic therapy within 30 days. We don't know if that was antiplatelet or anticoagulant. So a minority of patients in that study, but again, antithrombotics are withheld after major bleeding for concerns about causing harm with bleeding and uncertainty about whether or when it's safe to restart. So if we think about our case of a 78-year-old male who had a traumatic subdural hematoma, how would your decision-making change if the patient had a spontaneous lobar hemorrhage? So here, the concern is around a high-risk bleeding lesion like cerebral amyloid angiopathy. Would you A, recommend apixaban 2.5 milligrams BID, B, refer for left atrial appendage occlusion device, C, recommend low-dose aspirin, D, recommend warfarin, or E, recommend that he remain off of antithrombotic therapy indefinitely? And this is actually almost a trick question because, of course, we don't really know the optimal strategy for management of patients. And it is really an individualized decision based on understanding the type of bleeding event, including both the risk of thrombosis and the risk of rebleeding, in collaboration with the patient, their caregiver potentially, and also multidisciplinary folks who manage. For example, in this case, it may be helpful to engage a neurologist about understanding the risks of rebleeding. So in many cases, particularly cases of cerebral amyloid angiopathy, the risk of rebleeding may be deemed to be too high to restart anticoagulants, and these patients are often referred for left atrial appendage occlusion, which of course requires some duration of treatment, at least with single or dual antiplatelet therapy. So there is some antithrombotic exposure, but again, there is no evidence-based answer for this question at this time. So what do we do in clinical practice? Well, we know that anticoagulants are often stopped permanently despite thrombotic risk. We know that observational data is mostly derived from warfarin-treated patients. And then we also know that the optimal timing is not established and varies widely. And this is a slide that reflects the clinical equipoise that exists about restarting anticoagulants after intracranial hemorrhage. You can see on the left-hand side of the screen for cerebral amyloid angiopathy, the majority of people in this survey indicated they would never restart anticoagulants, whereas for head trauma, the majority of people would restart, although the timing of restart was variable. Similarly, after trauma, you can see that this is a study which shows that there was quite a high degree of variability in terms of restarting anticoagulants from the time of injury. And this variability really does depend on the type of underlying intracranial hemorrhage. And you've seen this image before showing that different types of bleeds, depending on the mechanism of the bleed, has a different rebleeding risk. And of course, it's the rebleeding risk that we are concerned about with regards to restarting anticoagulation. So we conducted a large cohort study which showed that in patients who had anticoagulant-related bleeding, here we looked at all types of bleeds, but if we focus on intracranial bleeding here, you could see that individuals who restarted anticoagulants had a lower risk of thrombosis here. In intracranial hemorrhage, it was not statistically significant, but there were not very many events, so likely underpowered to detect that difference, but an increased risk of bleeding. You'll also see here that patients who restarted anticoagulants had a lower risk of mortality, and this could be because of differences in baseline characteristics that would be prognostically important. Of course, these patients were not randomized to treatment strategies, and it may have been that baseline characteristics influenced the treatment decisions of the clinicians who were providing care for the patients in this study. So important to keep that in mind. Although we're seeing a signal here, in general, resuming anticoagulation reduces thrombosis, increases bleeding. As I've told you, the outcomes after anticoagulation restarting vary by the mechanism of the intracranial hemorrhage. So here we're looking at patients who had hemorrhagic stroke, and you can see that in individuals who had hemorrhagic stroke, those who restarted anticoagulants had a reduced risk of all-cause mortality compared to those who did not. And again, we keep in mind that these were patients who were managed out there in routine clinical practice, and that they may have had prognostically important baseline characteristics that led to the decisions to either start or not start anticoagulants. And it's possible or likely that the patients who resumed anticoagulants here had a better prognosis overall compared to those who did not. This slide shows the population of patients who had traumatic intracranial hemorrhage while receiving oral anticoagulant therapy. And you can see that in this population, the results are slightly different. Those who restarted anticoagulants had a lower risk of recurrent intracranial hemorrhage, all stroke, and all-cause mortality compared to those who did not. So quite different, important to understand the mechanism of the bleeding. In this meta-analysis, you can see that, again, individuals who restarted anticoagulants after intracranial hemorrhage had a lower risk of arterial thromboembolism. And in this study, there was no increased risk in intracranial hemorrhage that was found. However, we know that these patients were treated in routine clinical practice, were not randomized to a strategy of restarting or not, and therefore, we interpret these results with caution. We don't have very much randomized trial data, but this is a pilot study that was a randomized study done in the UK and in many centers. And this trial was testing a strategy of restarting versus not restarting, and it was a non-inferiority design. You can see that restarting anticoagulants had an increased risk of rebleeding that was not statistically significant, with a hazard ratio of 2.4. Again, small sample size here, only 200 patients. You can also see that among people who restarted anticoagulants, the frequency of recurrent spontaneous intracranial hemorrhage there were 8 events, and in the avoid strategy, there were 4 events. But importantly, with regards to ischemic stroke, there were 3 ischemic strokes that occurred among patients who restarted and 19 ischemic strokes in patients who restarted. So again, we're waiting for additional high quality evidence from a large definitive randomized trial, which is being conducted right now in order to answer this question. But we're always working with this balance of thrombotic events and bleeding. So what do the guidelines say? So there are some guidelines that address this issue, mostly in patients with atrial fibrillation who have spontaneous intracranial hemorrhage. And in the AHA-ASA guidelines from 2022, the recommendation here or suggestion is that anticoagulation can be resumed depending on weighing the benefits and risks. And of course, this is challenging because physicians may not have the tools to be able to do that, and the evidence is sparse. Similarly, if we're going to restart anticoagulation in patients with atrial fibrillation and spontaneous intracranial hemorrhage, the suggestion here is that 7 to 8 weeks may be the optimal time to do so, but only after weighing specific patient characteristics, which are not well described, unfortunately. And then finally, in patients with atrial fibrillation and spontaneous intracranial hemorrhage who are ineligible for anticoagulation, then the suggestion here is that left atrial appendage closure may be considered. And this slide just summarizes the randomized trials which are underway in this space, mostly in patients with atrial fibrillation who experience spontaneous intracranial hemorrhage. There is one trial, RESTART-T, that is evaluating patients who've had traumatic intracranial hemorrhage. Again, we're left with how do we approach anticoagulation after bleeding in routine clinical practice? What do we do in our own hospitals? Well, it's important to have some approach, I think, and that helps with individualized decision making. The first question really is, has the bleeding stopped? And if it's not, then we're really down another pathway, which is to manage bleeding. If the bleeding has stopped, it's important to assess whether there is an ongoing indication for anticoagulation. And if not, then that's much more straightforward. If there is an ongoing indication, then we really need to evaluate both the thrombotic and the bleeding risks. And I encourage you to think about these risks in terms not just of the type of thrombosis, for example, or the absolute risk of thrombosis, but the short and long-term effects. So a deep vein thrombosis has different implications for patients than an ischemic stroke, and that's important to recognize. On the bleeding risk side of things, it is critical to understand the site of bleeding and the etiology and whether or not interventions were undertaken to stop the bleeding, or interventions could be undertaken in the future to stop bleeding. The absolute risk of bleeding is helpful, though we really don't have very much data about that. And then the short-term and long-term effects of bleeding are really important. Finally, this should be done in conjunction with patients and families to ensure that they're on board, and recognizing that these decisions can change over time. And then if anticoagulation are resumed, we're really going to be, doing so in a thoughtful and multimodal way by assessing different aspects of the patient and in the context of their own health. So as we wrap up this session, there's a few takeaways that I'd like to focus on. First, remember to manage patients with regards to bleeding using a framework. And that includes these concepts. Prevention is the first step. So it's important to evaluate the patient and provide optimal anticoagulant care that's safe and appropriate, to protocolize management with early supportive measures and interventions like interventional radiology, like surgery as needed. Reverse anticoagulant effect for patients who have severe life-threatening bleed, and if reversal agents are not available, hemostatic therapies like PCC can be given. And then finally, reassess anticoagulants after bleeding. The issues around whether and when to resume anticoagulation are still unresolved, but it's important to go through this process, and it may be important to go through this process over time as decisions may change. And all of this is really being done with regards to a long-term approach to anticoagulant management. This is not a one-size-fits-all approach, and it's not a one-and-done type of interaction. Indication, lab testing, addressing concurrent medications, choosing the right dose for your patient, education and counseling, and then routine follow-up. These are all really important to safely manage patients over time. And really the key here is to evaluate and address modifiable risk factors for bleeding as they arise. And I thank you very much for your attention.